Let's dive straight into a high-yield, rapid-fire threshold logic drill for your final Step 2 CK sprint. No fluff today. We're focusing strictly on screening, vaccines, prevention, and those tricky do-not-screen scenarios. Let's get right to it. First up, we've got a 68-year-old asymptomatic male, a former smoker, who has a 4.2 centimeter abdominal aortic aneurysm discovered incidentally. So what's the best next step? The answer is an ultrasound every 6 to 12 months. The crucial threshold here is size. At 4.2 centimeters, it's considered medium, which strictly dictates 6 to 12 month surveillance. Now, a tempting trap here is emergency repair, but you'd only flip to emergency CT or emergency repair if he had an unstable presentation, like abdominal pain or hypotension, or if that AAA was rapidly enlarging or over 5.5 centimeters. Moving on. A 42-year-old male presents for a checkup and tells you his father was diagnosed with colon cancer at age 55. What's the best screening step here? It's a colonoscopy right now. Having a first-degree relative diagnosed under the age of 60 means you absolutely must start screening at age 40, or 10 years prior to their diagnosis, whichever comes first. The trap here is waiting until age 45. That only becomes the correct answer if his father had been diagnosed after the age of 60, which would put our patient back into the average risk pool.
Okay, try this one. A 32-year-old female with a history of childhood abdominal pelvic radiation for lymphoma comes in. What is her best colon cancer screening step? It's a colonoscopy right now. Prior abdominal pelvic radiation is a massive risk enhancer. It drops the screening age all the way down to between 30 and 40 years old. The trap here is choosing a fecal DNA test at age 45. You'd only flip to that answer if you had an average-risk 32-year-old female with absolutely no history of radiation or family risk factors.
Next case. A 38-year-old female has a normal pap smear, but shows atypical glandular cells, or AGC. What's the best next step? Endometrial sampling. The age threshold is the absolute key here. Any woman aged 35 or older with AGC demands that you rule out endometrial hyperplasia. The trap is to simply return to routine 5-year co-testing, but that trap only flips to the correct answer if she were under 35 with zero risk factors for endometrial hyperplasia.
All right, a 28-year-old non-pregnant female has CIN3 on biopsy. What's the best step? An excisional procedure like a LEEP followed by HPV testing at 6 months. CIN3 is high risk, guys. The trap here is simple observation. You would only flip to observation if the patient had CIN2 and was a much younger woman, where spontaneous regression is actually far more likely.
Let's look at a 32-year-old Ashkenazi Jewish female whose mother had bilateral breast cancer at 48. She tests positive for BRCA. Best screening step? You want concurrent transvaginal ultrasound and CA-125 every 6 months. The clue is that high-risk hereditary cancer syndrome. BRCA positivity triggers strict biannual ovarian surveillance starting at age 30. The trap is waiting for a routine mammogram at age 40. That only flips to the correct answer for a patient with a negative hereditary cancer syndrome test who falls strictly into average risk guidelines.
Here's a classic. A 28-year-old female at 12 weeks gestation is found to be rubella non-immune. Best prophylaxis step? Immediate postpartum vaccination with the MMR vaccine. The absolute rule you have to remember is that live vaccines are contraindicated during pregnancy. The trap is administering the MMR vaccine today. You would only flip to giving it today if the patient was not pregnant and presented instead for preconception counseling.
Sticking with pregnancy, a 32-year-old female at 14 weeks gestation presents for a routine visit during flu season. Best vaccine step? The inactivated influenza vaccine, right now. The inactivated flu shot is perfectly safe during every single trimester of pregnancy. The trap here is the live attenuated intranasal influenza vaccine. That's strictly contraindicated here. It only flips to being correct for a non-pregnant, non-immunocompromised patient who specifically requests needle-free administration.
Next up, a newborn is delivered to a mother with an active hepatitis B infection. Best prevention step? You need to administer both the hepatitis B vaccine and hepatitis B immune globulin within 12 hours of birth. The clue? Active maternal infection carries a 90% risk of vertical transmission, which requires dual therapy, both active and passive immunization, immediately. The trap is giving the hepatitis B vaccine alone. That only flips to correct if the mother is confirmed hepatitis B surface antigen negative.
Okay, a 3-year-old treated with IVIG for Kawasaki disease 3 months ago is now due for their MMR vaccine. Best step? Delay live vaccines for 11 months.
The IVIG treatment is composed of pooled antibodies, which actively alter a person's immune response to live vaccines. The TRAP is administering the MMR vaccine right now. That TRAP only becomes the correct answer if the child was treated with high-dose aspirin alone, without the IVIG.
Let's pivot to psychiatry. A 17-year-old teenager with active suicidal ideation refuses parental notification. Best step? Immediate hospitalization. The threshold logic here is that safety completely overrides confidentiality. You can even admit involuntarily if necessary. The trap is discharging the patient with a safety plan. You only flip to a discharge with a safety plan if the suicide risk is strictly non-imminent, they lack active intent, and their social supports are very strong.
Next case, a 28-year-old female develops a DVT after starting oral contraceptives. The OCPs are stopped. What is the recommended duration of warfarin? A minimum of 3 months, maximum of 6 months. The DVT here is provoked by a reversible, time-limited risk factor, the oral contraceptives. The trap is lifelong anticoagulation. This flips to being the correct answer only if the patient has an inherited hypercoagulable state, like a protein C deficiency with multiple DVT sites.
Moving on. A 32-year-old male with a BMI of 31 and well-controlled HIV presents for a checkup. Best screening step? A comprehensive foot exam, lipid, blood pressure, and diabetes screening right now. Why? Because being under 35 with obesity plus a risk-enhancing comorbidity, like HIV, triggers early diabetes screening. The trap is to reassure and wait to begin diabetes screening at age 35. You'd only flip to that trap if the patient was overweight but had absolutely zero additional risk-enhancing comorbidities.
Here we have an 8-year-old boy presenting with severe hypertension and recurrent flash pulmonary edema. Best test? A renal ultrasound with Doppler. The clue is the flash pulmonary edema in a pediatric patient, making renal vascular disease the most likely secondary cause. The trap is sleep apnea screening. That flips to correct if you had an obese adult presenting with daytime somnolence and a large neck circumference.
All right, a 6-year-old has a fever, tender anterior lymphadenopathy, tonsillar exudates, and no cough. Best step? Empiric penicillin or amoxicillin. This child hits a Centaur score of 4, which allows you to treat without even waiting for a rapid test. The trap is doing no testing or treatment. That answer only flips to correct if the Centaur score was 0 to 1, indicating a viral etiology.
Next, a 45-year-old female has a simple but tender breast cyst on ultrasound. Best step? Fine needle aspiration. The tenderness is the trigger here. The trap is simple observation. You only flip to observation if the simple cyst is completely asymptomatic.
Back to pregnancy. A 30-year-old female at 10 weeks gestation has hepatitis C. Best management? Administer Hep A and B vaccines and strictly avoid Ribavirin. Ribavirin is highly teratogenic. The trap is scheduling a cesarean delivery to protect the infant, but C-sections are not protective here because vertical transmission is tied directly to the maternal viral load, not the mode of delivery.
Similarly, a newborn is delivered to a mother with an HIV viral load of 5,000 copies. Best infant prophylaxis? Multi-drug ART. Because the maternal viral load is over 1,000 copies, the risk is high. The trap is zidovudine monotherapy. That is the exact right answer only if the maternal viral load was suppressed strictly below 1,000 copies.
Now, a 10-year-old presents with fever, nuchal rigidity, and focal neurologic deficits. Best step? Emergent blood cultures and empiric antibiotics before getting a CT and lumbar puncture. The focal deficits are a massive alarm symptom. The trap is an immediate lumbar puncture. That is strictly contraindicated until a CT scan clears the patient for elevated intracranial pressure when focal deficits are present.
Next case, a 28-year-old female, 4 weeks postpartum, feels overwhelmed and tearful. She has no prior psychiatric history. Best screening? The Edinburgh Postnatal Depression Scale. The absolute rule is that all women require postpartum depression screening, regardless of their psychiatric history. The trap is reassuring her it's normal baby blues without screening. What's the flip? Trick question. There is no flip. Universal screening is always required.
Moving to geriatrics. An 82-year-old female with advanced chronic kidney disease and limited life expectancy has unintentional weight loss but no red flags like bleeding. Best step? Watchful waiting and nutritional supplements. In the elderly, with a clear alternative cause for cachexia, like CKD, you must avoid invasive diagnostic testing that won't improve their quality of life. The trap is a pan-CT scan of the abdomen and pelvis. You'd only flip to aggressive screening if a younger patient presented with new minimal bright red blood per rectum and weight loss.
All right, a 14-year-old female is newly diagnosed with Turner syndrome.
Best cardiovascular screening step: 4 extremity blood pressures, an ECG, and echocardiography. The diagnosis of Turner syndrome is an automatic trigger for comprehensive baseline cardiac imaging because of the high risk of aortic coarctation and bicuspid aortic valves. The trap is to simply reassure and observe. You'd only flip to observation for a 46XX patient with normal development and normal stature.
Next up, a 35-year-old male presents with minimal bright red blood per rectum. Hemorrhoids are clearly identified on exam. He has no family history of cancer. Best step: no further evaluation necessary. Age under 40 with an identified benign source and 0 red flags means you stop the workup cold. The trap is a colonoscopy. This instantly flips to a colonoscopy if the patient is 50 years old or if they have red flags like a change in bowel habits, weight loss, or iron deficiency anemia.
All right, let's lock this in. Here is your final 60-second threshold checklist. Trace the exact age and risk factor cutoffs. Flag the live vaccine contraindications in pregnancy. Note the 11-month live vaccine delay after IVG treatment. Check the immune status and CD4 counts for HIV patients. Pay attention to the exact timing of exposures for PEP. And most importantly, always evaluate whether a screening or diagnostic test will actually change management. If life expectancy is limited, step back. Trust your threshold logic.